Hello, my name is Ricardo Despradel. My pronouns are him, his. I am a Dominican American counselor based in Brooklyn, and today I'm going to talk to you about cultural adaptations of evidence-based models. So before we start, I want to begin by defining culture itself. So culture is a dynamic process involving worldviews and ways of living in a physical and social environment shared by groups, which are passed down from generation to generation and can be impacted by historical events and by its interaction with other cultures. So I really want to emphasize that culture is a dynamic process, and therefore the study of culture or cultures is dynamic itself. So when we talk about cultural competence, which is tied to cultural adaptations, or it's in a way of cultural adaptations are in a way of form of cultural competence. Cultural competence is often described as something static, as something that you achieve and then you're just able to maintain it naturally. But considering that culture itself is dynamic, it makes sense that cultural competence should also be a dynamic concept, meaning that that class on Latino studies that you took in 2012 is probably not that relevant anymore or as helpful as it was back then. So some authors have gone so far as to conceptualize cultural competence as a continuum, almost like a spectrum. This goes all the way from cultural destructiveness. This is when agencies or individuals develop policies, behaviors, interventions that directly and negatively impact a specific cultural group or community. An example of this can be a faith-based practice or clinic that offers conversion therapy and doesn't allow or discriminates against LGBTQ um, identifying population or people. So it goes all the way from this side of destruction all the way to cultural proficiency. And cultural proficiency is the complete opposite. Is when you develop interventions, behaviors, policies, research that are meant to improve the quality of life or mental health of a specific group. And they don't only develop these policies, interventions, etc., they also disseminate it. That's a big part of being culture proficient. Not only doing your job well, but also teaching others how to do your job. And if you take a look at this graph, you'll notice that cultural competence is not at the end of the spectrum. It's not set as the ultimate goal or the ultimate level of culturally sensitive work that you could achieve. And we'll talk a little bit more about that. The reason why cultural competence is not the highest level of cultural sensitive work that you can achieve is because in some ways, cultural competence isn't a completely real term or is more of like a mythical term. It's something that we hear about a lot. People claim to have achieved it. Some people have seen it, some people haven't. But in reality, it's not standardized. There isn't a standardized definition of what cultural competence is. There isn't consistency in the literature, in the practice. Even with the American Psychological Association, the APA, requiring all graduate programs to include courses on cultural competence, these cultures, much like the concept itself, are not standardized, meaning that in a specific area, schools could be teaching cultural competence in completely different ways. And by areas, I don't mean like different countries or even different states. I mean in the same borough, all schools can be teaching cultural competence in a completely different way. Um, there's also people that are opposed to the idea of cultural competence. There isn't a consensus in cultural competence being a relevant or necessary thing. Some people argue that it minimizes and stereotypes people and mental illness, and that it neglects or also minimizes other factors that might be involved in psychological treatment. Also, cultural competence doesn't necessarily mean anti-racist. And I say this because a lot of people associate cultural competence with positive treatment outcomes. It is possible to get positive treatment outcomes and at the same time suffer or perpetuate microaggressions in treatment. And if you're a person of color, or gender, sexual minority, you've probably experienced something like this, where you might have gone to your medical provider because you had a health issue. Um, they examine you, they prescribe you something, they fix your problem, and you get the treatment outcome, but something in your interaction with them, this makes you feel kind of like, I don't feel comfortable with this person. And you did get your positive treatment outcome. You did get healed. You got your treatment, but it didn't feel right. And this could also happen in psychological treatment where you might, your therapist might help you get over your depression, your anxiety, and at the same time make comments or do things that could be considered microaggressions or racism. So even though cultural competence is this very vague term, a lot of people have tried to make it more concrete and more coherent. And they've done this by doing cultural adaptation frameworks, meaning this is a way of adapting evidence based models to different cultural groups. Here are a couple of examples, but I want to focus on my personal favorite model, the Hyman core model. And I really like this model because they divide evidence-based interventions into three concepts: cultural concepts of distress, treatment components, and treatment deliveries. So this is basically breaking down treatment, psychological treatment, into pieces. And I will talk about each piece individually. So the first one is cultural concepts of distress. When we talk about cultural concepts of distress, these refer to the ways or the narrative that specific communities or groups have of talking about mental illness and also how to treat them. Just to give you an example, I am from the Dominican Republic, and over there we have this concept called ataque de nervios. So it's a very vague term. It's not like a clinical term, but it's often used to refer to the presence of mental illness. It doesn't specify what kind of mental illness it is. It just lets the other person know, like, oh, we're talking about mental illness. And yet, much like my culture, other culture and other groups have their own way of talking about mental illness and the ways that they treat it. So when we're working with someone from a specific cultural group, we want to get that. We want to get that information of what their concept of their emotional distress is and incorporate that in treatment. Something that I personally have learned from practicing motivational interviewing for many years now is that even though we have a lot of academic knowledge, a lot of clinical knowledge, at the end of the day, the only expert in the client's life is the client itself. And they should be a part of the treatment conceptualization and the treatment plan. Our job is not to define these things for them, at least not most of the time, but to help nourish their experience and help them develop the self efficacy they need to overcome this emotional distress that they're going through. Also, the way that you can learn what the clients or patients' cultural concepts of distress are, there's two ways. There are structured interviews. There's a really good one called the McGill Illness Inventory, and it's basically a clinical interview that has these questions included of like, how do you define depression, for example, and how does your family define depression? What has depression looked like in your community and your family versus how it looks like in your own life? And then there's all the relational techniques, just having a very open and the conversation about it of like, what has been your experience? What has been your family's experience? How have you seen, what conversations, if any, have you heard or interacted or had about mental illness? Then there's treatment components, and these are divided by non-specific elements and in-session techniques. So the non-specific elements are things that are common among all psychological interventions like active listening, empathy, open-ended questions, etc. These are, regardless of what model you use, you're probably using these techniques. And then there's in-session techniques, which are the techniques that are specific to that model. If we're talking about cognitive behavioral therapy, it will be like cognitive restructuring. If we're talking about motivational interviewing, it will be cultivating change talk, reflections, etc. Then there's the treatment delivery, and this is the way that you deliver the intervention itself. If you're doing individual sessions, if you're doing couple session, groups, remote sessions, etc. And then there's surface elements. So these are very minimal changes that you can do or adaptations. Let's say if you're using pictures and you're working with children, to have people of color in those pictures, or people that look and represent the groups that you're working with or that client belongs to. And these are things that all of us, if you work with people of color, gender minorities, sexual minorities, any specific group, you're probably doing this in some way. Like you probably have been adapting interventions based on your own experience and based on what you think works and feel like it works, and you've seen that it works. So I know you're probably saying like, okay, this is all good, Ricardo, but like, what? How do I do this more efficiently? Like, well, what does this even look like in the real world? So I'm going to show you. I'm going to give you two examples. The first one is this really interesting study that was done by culturally adapting CBT for Latino women with treatment-resistant PTSD. And the way that they did this is that they took the key concepts of that intervention, of that CBT intervention, and they did slight adaptations to each one of them. So if we were to use the framework that I was talking about earlier, they focus on the treatment components. So here, you'll see that, for example, for loving kindness meditation, which is a technique that is taught to the clients, they use the same meditation, but they added cultural consonant imagery. What I mean by this is that they use, for this case specifically, they use religious imagery that was consistent with that group's religious beliefs. For example, modifying catastrophic cognitions about PTSD, they use the concept of ataque de nervios. Like they taught their clients that, you know, just because you're experiencing symptoms doesn't mean it will reach the, or it will escalate to the point of getting an ataque de nervios. And they did this, like they added little things. They maintained the core concepts of the intervention itself, but they embellish it with the clients or the client group culture. Another way of doing this is by expanding what the intervention covers or targets. For example, in this study where they adapted motivational interviewing to address heavy drinking or alcoholism, and motivational interviewing has this very specific characteristic that it works with target behavior. So it's very laser focused on one thing. That's the standard MI. So here they expanded that. Even though they have their target behavior, which is heavy drinking, they also included how their environment affects that heavy drinking and their concept of heavy drinking and what leads or feeds that behavior, by including family dynamics, social support, knowledge about alcohol, not just at an individual level, but also as a community. What does your community say about alcoholism? What facts are well known? What misconceptions are spread around in your community? And they still maintain their target behavior, but they expanded the way that they talk about it or they address it. And I just want to emphasize that also, you know, like I said, we've all been doing this in some ways. And when I was talking about cultural concept distress, for example, each culture, each community has their own way of dealing with emotional distress or mental illness. And they have been doing this for generations. Like psychologists didn't invent how to talk to people or talking to feel better or changing the way that you're thinking to feel better or meditation, etc. Like they did not do that. They what they do is that they take from communities and groups things that work, things that have a therapeutic effect on them. They standardize it and then they um, try to distribute it almost like if it was a product. Like if you take a very a local delicacy and try to spread it around the world. But what happens then is if someone from a different culture attempts that or tries to use that to alleviate their emotional distress, it doesn't always have the same impact because there isn't this cultural resonance with it. It lacks this level of meaning that other groups have. So, we've talked about different ways. We've seen that there's different ways to adapt interventions. The cultural competency itself, it's not the final frontier. It's not, we should hope and expect to achieve more than that. But then why isn't this a thing? Like, why aren't we taught in school, in our programs, how to do these things? We've seen their interventions. There are cultural adaptations, but why is it so hard to come across them? Why do you have to come to this talk to learn about this? um, and there are many reasons for that. One of the reasons that I mentioned is that graduate programs are not consistent with their courses related to culture or diversity. The one agency that's part of the NIH that's in charge of doing this kind of research and adapting interventions is the lowest funded agency of NIH. Cultural adaptations require a higher proficiency and understanding of the model that you're trying to adapt. If you're trying to culturally adapt CBT, it's not enough to just know CBT. You have to be really good at CBT to be able to kind of break it down and do very intentional and mindful changes to get the desired treatment outcome. Like I said before, there are still people that debate that cultural competence is harmful and is not actually helpful for people. And there's also racism. A lot of these barriers wouldn't exist if racism wasn't a thing. If there was no racism, it would probably get better funding for this research. People wouldn't be arguing what if cultural competence is even necessary. Um, so racism is a big part of why we have to kind of do all this extra work to provide culturally sensitive treatment to our clients. So that's all I have for you today. This is my contact information. I am a counselor at Discovery Mental Health Counseling, which is a private practice, it's a group practice where most of our members are Latinx, and we work with the Latinx community as well. It is part of a bigger company called Nurture We. This is my contact information. If you have any questions, if you want to share your experience adapting interventions, feel free to reach out. And yeah, this is everything I have.